And then before we begin, I am going to launch an anonymous poll. And it's just helpful information for us to know kind of the journey that you're on, what you're going through, and how we might be able to accommodate your needs in the future with regard to talks like these. So please fill that out. That would be very, very helpful. But now we're going to get started. So Dr. Patel, if you want to go ahead and advance to the second slide, I'm going to go ahead and welcome you and get this thing going. So good evening, everybody. My name is Christy and I work for Medtronic. And tonight I have the pleasure of hosting this webinar where you're going to get to hear from Dr. Neal Patel. Dr. Patel is a Georgia native and he earned his medical degree from Chicago Medical School as part of an engineering and medicine program with the Illinois Institute of Technology, where he graduated cum laude with a degree in molecular biochemistry and biophysics. After completing residency in urologic surgery at Rutgers, he joined the USC Institute of Urology as a Felix and Mildred Yip Fellow. Dr. Patel has co-authored a number of publications, patents, and textbook chapters, as well as presented research at many national conferences. He's been nationally recognized on his work with neuroprotective nanosphere drug delivery technologies, as well as cytoreduction for metastatic prostate cancer. I mean, some of these things are just so big, they're a mouthful, right? And they're profound accomplishments that he has. So it's fun to introduce him. He's also founded 2 medical device companies, and he has a keen interest in medical and biotechnology that improves the patient experience as well as patient outcomes while decreasing the cost of healthcare in the US and around the world. And while Dr. Patel enjoys all of this and he enjoys all aspects of urology, he does specialize in new advanced robotic surgery techniques, as well as voiding dysfunction, which includes overactive bladder, urinary retention, and fecal incontinence, which are all topics that we're going to be discussing tonight, along with a therapy called InterStim that helps to treat those conditions. And as I mentioned, I work for Medtronic, and that's actually the company that developed this InterStim therapy. And while you might not know the name Medtronic, you probably do know somebody who's had a pacemaker, and that's what we're most known for. So without further ado, I'm going to pass the mic to Dr. Patel so you can hear more about this. But before I do, just a few last reminders. Again, everybody's phones were muted upon entry. It is an anonymous event. So if you have a question, type it in the Q&A box at the lower portion of your screen. Again, the names remain anonymous. We'll get to those questions after the presentation. Likewise, please answer the poll questions that I just launched and that I'll launch later at the end of the event. So now allow me to welcome Dr. Neal Patel.
Hi, good evening, everyone, and thank you for taking time out of your day today to come in and hear about voiding dysfunction. Thanks for the introduction, Christy. You know, it's a really interesting thing. I mean, you know, out of all the things that, you know, I've done and been really interested in, including robotic surgery and cancer, it's been a full circle for me personally, because one of the greatest satisfying things I've found about being a urologist, surprisingly, is not helping people with cancer. I mean, it is a lot, but the satisfaction I find in helping people urinate better and improve their quality of lives, it is such a more palpable thing because you feel it every day. And being able to help that and fix that, you know, to improve just your daily quality of life is actually a very satisfying thing for me as a physician. And so, you know, over the years that I've been practicing, I have slowly migrated to doing a lot more work in voiding dysfunction, just because it's enjoyable. We see great outcomes and you know, really improve people's quality of lives at a level that they see every day. And so I'm excited to talk to you guys today about voiding and bowel dysfunction and really everything that's related to urination and when things go bad. So you know, one of the things that we're going to talk about today is, you know, overactive bladder. And really it comes down to control of your bladder. And it really becomes a issue as you get older. 1 in 4 women, 1 in 5 men will develop overactive bladder in the course of their life. And it becomes at a point where it starts to negatively affect your quality of life. You can't do your normal activities. You can't be social. You can't go for long car rides. You know where all the bathrooms are. You don't like to wear certain types of clothing. It becomes a social impediment, but also just it gets in your way. And it used to not be like that. And, as it starts affecting you on a daily basis, it's very important to go see a physician and get it figured out, because a lot of people don't. They think it's a normal part of aging, and they just resign themselves to either dealing with it or the diaper aisle at the local pharmacy. And so what I'm here to tell you is that it doesn't have to be like that. And as our bodies get older, it needs maintenance work, and that's what we're here for, and you shouldn't let it govern your life. So generally, bladder and bowel issues are something that do happen. And like I said, these are things that are sometimes in your control by what you eat and what you drink. But it could be more than that. It could be that the fact that you're urinating more than you need to. 6 times a day is normal. 1 time at night is normal. All of a sudden having to run to the bathroom, otherwise you're going to leak, is not something that's normal. If you start living your life around the bathroom, you go to the store, you use the bathroom. Before you leave the store, you use the bathroom. Before you leave the house, you use the bathroom. These are all things that begin to govern you. Using more and more pads to control leaks. Pads are useful, but they can also lead to foul smell, urinary tract infections if you don't change them enough. Monitoring how much you eat and drink. We encourage patients as they get older to drink more fluids, because we generally begin to drink less fluids and dehydrate ourselves, and that's not what we want. When you add overactive bladder on top of it, a lot of patients stop drinking fluid or foods that irritate their bladder, because then they don't have to urinate as much. And while that may help in some respects, it's actually not great for your health. The other most important thing here is getting up multiple times at night. There's a lot of reasons it happens. It's different causes in men and women. The underlying cause ends up also still being overactive bladder. But as you get older, one of the most common types of falls we see are in patients who are getting up at night to urinate. And so if we can reduce that to a point where you sleep most of the night and you're getting up early in the morning to start your day to urinate, that would be ideal. Like I said, you're not alone. This is a common problem I see. I probably take care of 5 to 10 patients every day I'm in clinic who come in with these issues. It affects people of all ages. I've seen it from 18 to 99. And there is a propensity as you get older that it is more prevalent, and we'll talk about why in a minute. But ignoring it is not the way to go, because you lose self-esteem, your social life takes a hit, you don't want to go out as much anymore. A lot of people have daytime sleepiness and fatigue because they just keep getting up at night and they can't go back to sleep. And just the feeling of having all these things happen to you can sometimes lead to just bad feelings about your general health. 1 in 6 people will have bladder control problems in their lifetime. And bowel control is not that much different, and it's sometimes less talked about because it is more embarrassing than even urinary problems. But bowel control and bladder control are actually very closely related from how your brain how your brain governs them and controls your brain and bladder, or bladder and bowel. So there are many treatments that we offer to fix this, and it starts simple, and then we work our way up, and we have a very good success rate with it. But before we get there, we want to talk more about what causes these problems. And so obviously things that you eat and you drink. If you drink lots of caffeine in the afternoon, you drink alcohol in the evening, these things can irritate the bladder. Spicy foods can irritate the bladder, foods high in acid, tomato-based foods, all these things can affect your bladder. There are medications that you take. Some people take what's called the water pill, which is really important for lots of other reasons, but it can make you make more urine. There's also diabetic medications that we see more and more these days that put the sugar in your urine so you pee it out to lower your sugar level, but also makes you urinate a lot more. And the other big thing is just being pregnant, having childbirth, vaginal deliveries, or C-sections. They can all lead to issues with urination where you're unable to hold your urine and you leak urine when you cough, sneeze, or laugh. So let's talk about how the control for the bladder works, and it's very similar to bowel. So generally, when you are born, your bladder is designed to just fill and empty. It has no other job in life. And as a baby, your body and your brain don't know how to control it. So you actually have a system in place deep down in your spinal cord to do the job for you. And that's why kids have to wear diapers until they're old enough to be potty trained. And then you go through a very, very intense behavioral therapy session with your parents known as potty training, where we have your brain take over control of your bowel and your bladder so that it keeps it calm in socially acceptable situations, which is a subconscious calm signal that's always being emitted from your brain and affecting your bladder until it's absolutely time to go. And then a different signal takes over and you urinate. Breakdowns in these communication systems can happen for lots of reasons over the course of your life. Surgeries, trauma, spinal cord injuries, brain injuries, aging, different changes to your spinal cord as you get older. All these things can affect the nerve signaling pathway from your brain to your bladder. And so what ends up happening is if the bladder is not getting that calming signal from your brain that has been used to all your life, that's allowed you to have control over it, then the baby brain sort of takes back over and starts doing a lot of this work where it just says, okay, I just need to empty, I need to store, I need to empty, and you lose that control. There are many other reasons why this happens. Sometimes the bladder gets really thick. Sometimes guys have enlarged prostates, the bladder gets really thick. And then the signal's just not making it to the muscle, because at the end of the day, the bladder's a muscle and it squeezes, and your brain controls when and how it squeezes. But if that bladder or that bowel is not getting that signal, then there are some backup systems in place to make sure that you get rid of the waste from your body. And in a similar way, bowel function works the same way. The signaling pathway, instead of your bladder, it's your rectum. And your rectum, your brain is able to control your rectal and sphincter muscles until it's absolutely necessary to go. But if that same signal is not making it to the rectum and the sphincter to stay calm, then you can get bowel accidents as well. And the same nerves that help with both bladder also help with bowel. So we see a lot of folks who come in with urinary problems, and then when we ask, they're like, actually, yeah, no, I'm having sometimes issues controlling my bowel movements, and I have incontinence, and it's very embarrassing. And people tend to not talk about that as much because that's very embarrassing to discuss. So when we go back to bladder control problems, there's sort of three basic ways that we stratify or we look at urinary issues. One is what we call stress incontinence. Stress incontinence is purely leakage when you cough, sneeze, or laugh, or do abdominal exercises or play sports, and you leak urine. It's common in women. It happens likely due to pregnancy, vaginal deliveries. It can happen in men after they've had surgery on their prostate. There's a lot of reasons why it happens. Also in women, if they get their uterus removed or had what we call a hysterectomy, sometimes you lose supportive structures in your pelvic floor, and all of a sudden you can't hold your urine anymore. There's the opposite of that, which is called retention. So retention is basically you are full, and either you can't feel that you're full, or that you're so full you can't empty your bladder, and it's very uncomfortable. We see a lot of people who come in for various reasons. Men are usually more prone to this than women, where the prostate has grown so big that they can't empty their bladder, and their bladder takes a big hit because they can't push the urine out. And the question is it because it's blocked, or because the bladder has just sort of given up on trying to push the urine out? Usually this requires a catheter. It can be presenting as initially as the stream just keeps getting weaker and then you can't pee. Women are not immune to this. We see many women who have been urinating the wrong way their whole life and never knew it. And as it turns out, their bladder just doesn't work, and they use more of their abdominal muscles to pee and not their actual bladder muscle. And so we get this situation where we cannot empty the bladder, which can lead to issues with kidneys. It can lead to issues with recurrent urinary tract infections, which can be miserable. And there are ways that we can use bladder control therapy to help this as well in certain situations. And lastly, overactive bladder. So overactive bladder is probably the most prevalent out of all of them. It affects men and women. It is just something that seems to get worse as you get older. There's lots of theories behind it. One is the fact that just the calming signal from our brain just isn't making it to the bladder anymore. But there are other things that happen in life, like surgery, or in men, an enlarged prostate can lead to an overactive bladder. But when it becomes a problem is when you start having that urge to go and you can't make it to the bathroom. A lot of people describe it as they get out of the car, they're trying to get to the front door, and they're getting their keys out. And just that alone, the anticipation of having to go to the bathroom the second they get in the house causes them to leak urine before they even make it to the bathroom. I commonly have patients who say, I wake up and I have the very strong urge to pee, and I'm running to the bathroom, and I sometimes cannot make it, and I'm leaking urine as I get to the toilet first thing in the morning. And these are things that can be really embarrassing. They can be things that maybe hit you when you're least expecting it. And they can be triggered by many things. I have some patients that say just the sound of running water can trigger it, or cold weather can trigger it. And these are all things that can be causing embarrassing situations. You may also just have urgency or frequency. You may have leakage, but you may have this constant urge to go to the bathroom. I have patients that come and say, I go to the bathroom every 15 minutes, or I go to the bathroom every hour. I can't leave or enter a place without going to the bathroom first. My life revolves around going to the bathroom all the time, and I never feel like I fully empty, and it's the most annoying feeling in the world. And these are all related to that bladder muscle being irritated or being overactive for various reasons. So in the similar vein, what is fecal incontinence? Again, this is something that goes along with bladder issues. It may not be related to you, but you'd be surprised how many people have it and don't talk about it. It's the same situation where you have the urge to have a bowel movement, but you can't make it to the bathroom in time, and you leak stool into your underwear or your diaper. Sometimes you don't even know when you go. Some people say they pass gas and this happens, or when they're trying to urinate, this happens as well, and it's unintended. So in those situations, there's a smell issue. There's wearing dark clothing. You have to wear pads. You plan activities around the bathroom. And so what do we talk? When we get to this, how do we approach these problems? Well, there's a whole pathway that we follow, and it starts simple. We start every patient on some basic changes to their lifestyle. We look at what they're eating, what they're drinking. We look at their diet. We look at what time they drink fluids. We look at how many times they get up at night. We actually have you write out a diary for 3 days on how often you go in the bathroom, how much of an urge there was. Did you have a leak? How bad was the pad? Did you change it? What did you have to drink? And try and start correlating some lifestyle changes first, because like I said, we like to start basic. The other thing that we look at is, can we retrain your bladder and your bowel just like it was when you were a kid? So you may have heard of Kegel exercises or pelvic floor therapy. We also sometimes do biofeedback therapy, but sometimes that is dependent on the ability of your pelvic floor therapist to do it. But there are many things that we do first to see if we can fix the problem naturally. I think everyone would love to just fix the problem naturally if they could. And that's what we always start with. A lot of times when patients come in, they say, look, yes, I want to do all this, but I want to feel better soon. I don't want to wait, 6 to 8 weeks of doing all these changes to see the improvement. And so a lot of times we'll go ahead and try you on some medications. The medications are Band-Aids. They do not fix the underlying problem. If it is a overactive bladder that's not being controlled by your brain, all the medicine does is it calms down the bladder physically. It goes into the receptors in the muscle, and it just tells them to calm down. And so the medicines are something that you have to take long term. It's lifelong to keep those symptoms at bay. And we have many patients on medicines. We have patients who do well on medicines. We have patients who don't do well on medicines because, as you know, medicines have side effects. They interact with other medicines. They can be expensive. And it's just as you get older, people tend to take more and more pills, and we try to find ways to avoid it. But we also always start as a second line therapy of medications. The medications also help me understand how your body responds to these medications. It helps us in our decision-making process on getting you to a successful treatment goal. Lastly, if medications don't work, and there are lots of reasons why they don't work, not just side effects, but people just tend to stop taking them. And then they go back to their old ways of leaking urine and running to the bathroom. And some patients just resign themselves to it. And at Advanced Urology, we do a lot of work to stay on top of it, to make sure that you are doing okay, that we don't just give you medicines and send you on your way and never see you again. We have navigators that follow up and make sure that the medications are working. And if they're not working, are you having side effects? Let's get you back in and really get you to a point where you don't feel like you're giving up on this. And so the next step is something called advanced therapies, is what we call third line therapies. Lifestyle changes is first line, oral medication is second, and then advanced therapies is third. Believe it or not, there's a fourth, fifth, and sixth, and usually we never have to go there. But this is not the end all. This is not like you get to this point. If it doesn't work, there's nothing else that we can do. But generally, most patients will be successful in advanced therapies. It's usually about 80 to 84% success rate if you look at the data across the country. And so like we talked about with lifestyle changes, diet, exercise, biofeedback, Kegel exercises, with oral medications, like we talked about, there are side effects that a lot of people don't like. So dry mouth, blurry vision, constipation, high blood pressure can be side effects. We do our best to look at the medications and look at you as a patient and say, hey, this medication would be safe for you, or maybe this medication won't be safe for you. There's a lot of data out there that certain classes of medications that help with overactive bladder long-term could cause early dementia. And so if you're over the age of 65, we say, look, we're going to stay away from those medicines. We don't want to do that. Let's try this class of medicines. And so we really tailor the pathway to you and your health and your age and your medical conditions. Sometimes medicines aren't allowed in certain patients with certain medical conditions. And we look at that and say, okay, look, if we can't do the medicines, then let's try, advanced therapies. So the biggest thing about medications is that it's just tough to stay on them for various reasons. It's just another pill that you take. They have side effects. The nicer, newer ones sometimes are really expensive and not really affordable long term. And so what ends up happening is, a lot of patients just don't come back because they feel like they are, that they just prescribed medicines and say, come back and see us in a year. And so we work really hard to make sure that that doesn't happen. We work to say, look, if the medicines aren't working, we're following up with you to make sure that, they're working or they're not working, and really get you to your therapeutic goal. When we talk about advanced therapies, there are a few options for treatment of advanced therapies when we get to this third line therapy. So for both bladder and bowel, there's a system called Medtronic's InterStim system. It is basically, if you had to introduce that calming signal to your bladder, that's what this system does. So it's fixing the problem at its core. So if we can't fix it with retraining your body or the medicines, or you don't want them, or you can't tolerate them, then we start talking about, okay, let's just fix the problem at the underlying cause. And a lot of patients come in, they say, I just want to do this right away. And, as much as we love to do that, there are reasons why. I mean, this is a costly therapy for insurance companies, and we want to make sure that we can try and fix this in the most conservative way possible before we get to this point. Like I said, this is not the most aggressive option. This is sort of a mid-tier option, and it's a very minor outpatient procedure. And so what we do is we say, look, if we've tried all this and it's not working, and we are worried about this being an overactive bladder, let's just do a test to see if we're right. And the test helps us understand if this is a nerve and muscle signaling problem. And the way we do that is you come in, it's like a 10-minute outpatient, very minor, minimal anesthesia or even local anesthesia. We just put a little wire underneath the skin, and the wire just sends a signal into the vicinity of the nerve that is supposed to be controlled by your brain. It's down low, sort of in the lower back area. And you go home and you try it out for 3 or 4 days, sometimes longer. And you'll know right away. Usually my patients say within 24, 48 hours, they'll notice an improvement, over right away. Like they won't get up at night, they won't have leakage, their pad usage drops. And what we look for is a 50% improvement, because the test trial is a very sort of flimsy wire. It's not meant to be permanent. It's not meant to fix the problem, but it's meant to show us that we're heading in the right direction, that yes, you in fact do have a nerve signaling problem. And by fixing that, it fixes your overactive bladder or your bowel. So if you do, then you come back a couple of weeks later and we put a tiny little pacemaker underneath the skin. It's a 15-minute outpatient procedure. You can, anyone can do it. It doesn't matter how healthy or unhealthy you are. I've placed it in 90-year-old patients who are suffering from this with local anesthesia, and they did absolutely fine. And so it's really just a minor outpatient thing. It's not a major procedure, but what it does is it helps fix your problem long term. And the Medtronic systems we love because the batteries last 15 years. And you sort of set it and then hopefully just forget about it. And then 15 years later, we change the battery, which is very easy to do. There are other options, specifically in the bladder realm. There's another procedure that we do. It's called Botox. Many of you may have heard of it, and Botox is considered another therapy that can be offered to patients in situations where the medicines don't work. Botox is done by putting you under general anesthesia, putting a camera into your bladder through your urethra. And then we use a special type of needle that we push into the bladder muscle inside your bladder and inject Botox. It is the same Botox that you hear about that people use on their face. And yes, everyone always jokes, can you leave a little extra for my face when you're done? The Botox helps relax the muscle and calm it down sort of at a physical way. So we're basically injecting Botox and it basically tells the muscle receptors to stop firing and it tells the bladder to calm down. With Botox, there are potential side effects. The main one is that it may work too well and then you can't pee, and it's not something that we can reverse. And so what happens is the Botox will wear out over time. So if you cannot urinate, you'll have to learn to catheterize yourself until the Botox wears off. And then the next time we can do a lower dose if we have to. Botox is something that has to be repeated. It's not a one and done thing like the InterStim device. So with Botox, you have to come back every 4 to 6 months. And we put the Botox in. Over time, we have to do it less often, but it is cumbersome and patients don't like having to keep coming in. We just want to help you get fixed and move on with your life and not really need to see us. Sometimes the InterStim system requires programming. There's 150 different programming settings that we can do over time to get you to the treatment goal. And so the other thing that we tell our patients, you got to be patient with us. It's not instant gratification. It's something that we have to work on. Every person is different, but we do a pretty good job of getting the right settings the first go around. With bowel control, it works in the same way. I've had lots of patients who never even told me they had bowel issues. And then after we do it for the bladder, they come in and they say, hey, does this work for my stool? And we said, because it's much better. And we say, yeah, it works on the same exact system. So we have patients who feel like they have better control over both, regardless of the reason that they got it. With bowel control, this is really the least invasive option. All the other options for bowel control require surgery on the rectum, which can be very uncomfortable and painful. Remember, this system goes nowhere near your bladder or your rectum. It is away from that, but it's able to still fix it. Like we talked about with Botox, it just has to be done repeatedly. It doesn't fix the underlying problem. It is essentially just telling the bladder to force it to relax. And a lot of people don't like to continue it. I've had patients who do really well with it, and I've had some patients who were miserable after it, and you just don't know until you do that first injection. There's another system called percutaneous tibial stimulation. It's doing the same type of thing that the InterStim device does, but you have to do it you have to do it very frequently. And it's something that some people offer. For us, we like to just fix the underlying problem. We don't want to have you come in every week for multiple sessions, but this is an option. And if this is something you're interested in, we can have referred to some of our colleagues in some of our other groups that do this. But it is essentially doing the same thing that the InterStim device does, but it's something that you do have to maintain periodically as well. And then the InterStim system itself, which we talked about, this is what corrects the underlying problem. I absolutely love it. I have found that my patients do really, really well with it. And for me as a physician, it's very satisfying to see those effects when the patients come in and they say, you sort of changed my life. I can pee again. I can take my long car rides. I can go to the bathroom. And that's what got me doing this more and more, because that level of appreciation you sometimes don't see with cancer. But you do see this when you fix something that is making someone miserable on a day-to-day basis. Again, it's a very simple, minor thing. It's very tiny, as you can see there. It is a 10-15-minute outpatient procedure. We do a test first to even see if it's the right option for you. So it gets you a chance to see the light at the end of the tunnel, like I like to call it. And it gets us diagnostic data so that we know that this therapy is right for you. There are multiple options to pick. There's a rechargeable option and a non-rechargeable option. Most of our, I'd say 95-98% of our patients usually pick I don't want to deal with this. I don't want to have to remember to recharge it. Just give me the 15-year and I'll come see you in 15 years when I need the battery replaced. But you do have two options. This has been around for a long time. So the other thing that's really important is that this is not new. This is not experimental. This is tried and true. This has been around for 30 plus years. And it's only gotten better, and really has gotten amazingly better in the last few years, because now it's fully MRI compatible. It's the technology is like based off of a similar, like your smartphone, for being able to control it. And the battery now lasts for 15 years. So it's really less of a effect on your life. It has an 80% success rate. And for those 20% of people that don't do well, sometimes we find a little bit of Botox plus the InterStim really helps sort of get them to, that higher success rate. The test is really so minor and so minimal to you that it's such a great option to at least try, so that you can see it for yourself. I tell everyone, just do the test, see it for yourself, and then make a decision. And everyone that has a successful test will eventually just get the full device in because they loved it so much. I've had patients who get upset when I have to take out the wire in the office because they're afraid of going back to the way things were. I had patients that come in and ask, can they just continue the test longer on the day that we're supposed to just remove the wire in the office to gauge how they did. And so, those are things that we look at. I mean, sometimes you do other things in medicine where you give a pill and you don't know if it's really helping. But again, this is something that's personally just satisfying as a treatment provider to do, because it works so well. Like I said, it's fully MRI compatible now. And so there's no issues with getting MRIs. Sometimes in past sessions, we've had patients who say, if I've had this placed 5 years ago, what can I do? Well, if you need MRI, we take out your old device, and then you get your MRIs, and then we put in a new MRI compatible device. And so again, it's very safe to do. There's no danger with having the system in anymore. So really, it comes down to, if you're on this call, it probably means that you or someone are having symptoms significant enough that you spent the evening on a Wednesday night to join this call with this doctor who really loves treating voiding dysfunction. And so, really what it comes down to is we don't jump to this. I think, we really work hard on trying to fix the underlying problem, but there are things in life that no matter how much we try, it always ends up saying we got to fix the underlying problem, where we do for most everything else in this world. And so a lot of people will be good candidates for this therapy. Like I said, it works really well. It's a great option to consider in the right patient. 84% satisfaction rate. People have reported that they've had a 3x improvement in their quality of life on surveys. And our bowel control data is even better. 90%, 89% of people who've had it for bowel control have seen great success. And I can personally say that the patients who go from having stool accidents to none, they are so happy and so grateful. They have a whole new, the depression and a lot of other things that come with it seem to almost disappear overnight. And it's fantastic to see when we do see that. It's been implanted around the world, 400,000 or 500,000 times now. It's tried and true, and people have done really well with it. And like I said, not everyone, this may not be the option for you, but it does work really well. And I just would say, look, at the end of the day, I think if you're having issues and you need to get it figured out, this is something I take, as a personal interest in my practice to do, and I love doing it. If you come to the office and you see me, you'll see what we're all about. I've made all these handouts over the years. I've aggregated data. We do great little talks and a lot of teaching, and it'll probably be a lot of the same things that you saw today, but more personalized to you. And we really do work hard to get you there, right? We look at you, we look at the patient, we say, okay, what are your goals? What are your treatments? What are you interested in doing? And we try and get you there. And we don't give up. We'll keep trying until we get you to where you're at goal. And so with that, please make sure you complete the poll. We've got patient ambassadors. I prioritize patients who have overactive bladder. I know how, once you've made that decision to come in and see, I know how important that is, because it takes a lot of effort, sometimes a lot of courage to do that. And so, if you just say, look, I need to see Dr. Patel for overactive bladder, we'll try and get you in as quickly as possible. I see patients in Johns Creek on some Mondays and almost all Fridays, and I see patients in our Brazelton office most Thursdays.
To that
So
point, I'm actually going to launch a poll about that. I'm going to go ahead and stop recording really quick, just so